Starting with my enucleation with thulium. It's an high-power thulium, so I will do it in continuous, so no more pulsed, with 220 watt and 40 watt for coagulation. First of all, I will do a U-shaped incision, embracing the verum montanum. Okay.
So this is a kind of classic thulium.
Yeah.
No, Giorgio. Yeah. Not the new ones.
You see that I'm just surrounding the verum montanum with a horseshoe incision. You see? Despite the other live surgery you've seen, due to the continuous emission, you have more carbonated tissue, but this won't be a big problem. Okay? So after that, in this prostate, we don't have a huge third lobe, but I always recommend to make the third lobe at all, just to have a good separation in between the capsule and the adenoma at 6 o'clock. So I'm doing this 7 o'clock incision just to detach the median lobe, or what we can call the median lobe, from the lateral lobe. And I'm doing it with the zigzag just to have, even here, a U-shaped incision, just to have space to move in between with my instruments. And I'm going just towards my U-shaped incision at the verum montanum.
How big is this prostate, Giorgio?
70 grams, they told me.
Yeah, it's a real volume, because the one from Jose is not much.
Oh, good.
When you get that kind of feeding, maybe very close to the capsule, you make some changes in the settings of the laser, or you try it always with the same settings that you are enucleating?
No. I'm using just like the same setting. And you see here at 5 o'clock, I have a very not that big third lobe, but I'm doing it just to have a good situation at 7 o'clock, at 6 o'clock, sorry, to detach on that part the two lateral lobe.
You usually perform a ThuLEP technique like this, or?
Yeah, usually yes.
Yes. To get a good space.
Yeah, this way I have space in between the lobes.
Yeah.
With my setting, you see, it's not just a cutting effect, but it has a little bit of vaporizing. So I have more space in between the two lobes. So there's a little bit of surrounding of vaporization. So I don't have a V-shaped incision, but it's a U-shaped incision. You see, it's just a little tongue or tissue. But now I'm going just downstairs. I do a little bit of traction, and I see that I'm in the correct plane, so I can go just underneath to enucleate this little part of the prostate, which is supposed to be my third lobe. You see, little traction. I feel that the plane is here, and I cut in between. A little bit of traction. I see the correct plane, and I cut in between. And this is the most simple part of the whole ThuLEP. Traction. Keep in mind that once you arrive really close to the bladder neck, you don't have to go straight, but you have to go up. Otherwise, you underminate the bladder neck.
Because problems with the catheter or a bleeding part through. Oh.
Sorry, I didn't get it.
No, I said that when you go below the bladder neck, it gets hard bleeding to hard to control or space. Then you have problems with the catheter, maybe.
Yeah, absolutely. So just keep in mind this. So little bit of coagulation on the capsule. And now we have 6 o'clock is done. We have a good separation in between the two lobes. And here we have the bladder neck. Now what I do is I go upstairs at 12 o'clock to make a first little separation on the commissura in between the two lobes. I really work attached to the bladder neck with the same zigzag movement that you saw before at 5 and 7 o'clock. Okay, so now we have an incision here, an incision there, and we can just make an incision on the lobe laterally. I am right-handed, so I start with the left lobe, and I just make a conjunction in between my two cuts. And before doing any traction on the lateral lobe, I cut the mucosa just to have no problem on the sphincter, because the transient incontinence we have after some ThuLEP or HoLEP are maybe due by the traction we do. And if we don't cut the mucosa first, the problem is that the mucosa is the most powerful part of the prostate that keep the prostate attached to the sphincter. Once we have cut the mucosa, when the inclination change from the urethra to the lateral lobe, you can do a little bit of traction, so you can find easily the plane in between the bladder neck, the capsule and the adenoma. So I've cut the mucosa and I've reached the incision I've made here. Now I go there, just next to the verum montanum, and with a little traction, like this one, I find out the correct plane. Traction, find out, I cut and coagulate in between, and I keep like that.
Giorgio, we are moving to the Tor Romero operating room, okay?
Absolutely.
Hola Giorgio, estamos contigo. We are with you.
Okay.
Now.
So I've already enucleated the left lobe.
The first.
Yeah, the first or the second, if we think that the first was the third.
You usually perform one side before the other, or you choose to start with one side or the other side, depending of the anatomy, or
no, depends on the fact that I'm a right-handed, and for my position, it's better to start on the left. And then I go to the right. So usually the second lobe, the right one, even the position of my hand is not the one I would prefer. The other lobe is easier to be enucleated because you have no contraction on the other side, because the other side is empty, and so I can make better traction on it. You see, it's very easy to enucleate it, because you don't have anything on the other side that makes you...
Exactly.
Yeah.
That is what we were talking about, the ThuLEP techniques and the advantages of the technique with Jose Placer in the other operating room, and we were talking about it. You have more room to mobile.
So you just follow
mobilization of
your first incision, and you be on the plane all the time.
So you perform a little blunt dissection.
Yeah, it's
and
a blunt
then,
dissection.
you identify the correct plane and then the correct layer, and then you apply the
Then
Thulium,
you just use the laser to cut when it's hard to be dissected just for the traction and for coagulation. So you made coagulation while you're cutting, and that's it.
You're surrounding the apical part of the prostate, and you continue with the anterior part, or you detach the sphincter now, the bladder mucosa.
Actually,
how do you do it?
I've already detached the sphincter while I was doing, like I've already done on it, but on the other side, the first part of my cut is the mucosa. When you cut the mucosa, in the area in which the urethra change is inclination, because of the prostatic lobe, you have detached the sphincter, so you can do the traction that you want to enucleate the adenoma.
Can you show us the sphincter of the first lobe when you could? Oh, okay.
Here you have the sphincter, and it's already detached, and this is the lobe I'm acting. Okay?
Yeah. But that is still the first lobe is still in there. No, it's not completely separate in the mucosa.
The other lobe is in the bladder, and it's somewhere here.
Oh, no, don't worry.
Here.
Okay. Yeah. But yeah, there's some.
It belongs to this lobe.
Yeah. We'll see.
Actually, it belongs to the same prostate, and
perfectly.
It's me that I've decided that belongs to this lobe.
Do you think you have to have some experience with enucleation with holmium before starting with thulium, or not? Because
actually, I've done the opposite pathway, because I did all my training with the thulium, and I'm doing now also holmium enucleation with actually the same technique. So I can tell you that, as I told before, enucleation is enucleation. You need an energy to do a correct enucleation. You choose, and I think that thulium is the way that forgive you a lot of mistake, but you can easily start with holmium and then shift to thulium. So it's not a problem. I was quite convinced that it was better to start with thulium, but actually there are a lot of persons that start with holmium and shift to thulium with no problem. The correct question is, start with an energy that you can rely on, and then adapt your technique to the other energy, and that's it. I think this could be the key point.
No, you have completely separated the sphincter. Now, so Giorgio, we are switching to the operating room with Javier, okay?
That's fine.
Pasan al quirófano número 2, por
Creo que
fin.
Giorgio terminó.
Ya ha acabado también.
Sí. Giorgio se ha acabado, ¿no? No. You have finished? No. You have the last piece of adenoma inside the fossa, isn't it? Giorgio?
Yeah, I'm morcellating now. I have the bladder that is a little bit empty, so I need to fill it up. But see, just these little pieces.
Do you prefer to? Do you like to perform the final morcellation or even
into the prostatic lodge? You mean?
In the fossa, or
only if the pieces is escaping too much, and I need to keep it in the right position, and it seems that I have to.
You prefer to do it in the bladder always? Because for me, as soon as I can, I put the adenoma in the fossa. Yeah, always. With these morcellators, you don't make any injury in the bladder, and you perform it quicker, faster. Because usually you don't lose the adenoma that much. Yeah, you have to put the blades a little bit more harder.
Can we have a better suction? Okay. There you go.
Estábamos comentando aquí que sobre morcelar en la fosa o morcelar en la vejiga. Con estos nuevos morceladores que son biselados, como veis, y tienen la ventana no exactamente encima, sino un poco encima y delante. Y estos morceladores funcionan muy bien cuando se bascula mucho y cuando lo diriges hacia el adenoma. La única manera de poder hacer esto sin tener riesgo de pegarle también un beso, como dice el doctor Mejide, a la vejiga del trígono, es hacerlo finalmente a intentar traerte el adenoma y traerlo a la cápsula prostática.
Sí, dime. Pues me pillas, pero eso se me avisa antes, tío, se pone y te van a preguntar. Pero suelen ser de 500 para próstata. No sé si está por aquí, no, les veo.
Porque en ese láser en particular se hacen menos burbujas si usas una de 365. Entonces quizás te estorbe menos la visión cuando utilices una de 365.
A mí para bajarlo de las burbujas, que además luego te acostumbras y no me es un problema, cuando lo utilizo y lo pongo en los settings que yo te digo, estoy más cómodo, carboniza menos y hace menos burbujas. La pena es que la próstata esta era bastante pequeña, por eso entonces no lo hemos podido ver bien, porque la que había dado COVID positivo y ha sido un fastidio. Me habría gustado enseñarlo porque luego vas muy cómodo enucleando. Y yo entiendo perfectamente lo que dices, Carlos, y cuando empezamos los del Holmium a cambiar a Tulio, tal, pero hablas con los del Tulio y es curioso porque ellos dicen que lo que no saben es cómo podemos hacerlo con el Holmium con lo acostumbrados a cortar, Giorgio, Bozzini, toda la gente que lo hace, en fin. Pero luego una vez le coges ya la dinámica, la cirugía y al tal, es muy rápido. Mira, de hecho, primeros pacientes que hemos hecho FL, tenemos ya una eficiencia de 3,1. Tenemos 3,1.